All right. Hello again, everyone. Good morning and welcome to our EHE Regional Learning Collaborative session on strategies to support access to HIV services. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPTS. For anyone who might be new to the collaborative, our purpose is to facilitate knowledge sharing and support collective action across California's EHE Phase 1 counties to help accomplish our shared EHE goals. And as always, we welcome folks from outside these 8 counties to join the sessions and learn together with us. So thanks to everyone on the line for joining us this morning. In the chat, you should see an option to send a message to everyone. If you haven't yet, please use that option now to introduce yourself to everyone on the call by sharing your name, affiliation, and location. Next slide. Enrique, can we advance to the next slide? Thank you. So during today's session, we'll be discussing different programmatic models and resources to help support access to HIV services here in California. We'll start with presentations from our 3 wonderful panelists, and the last 25 minutes or so will be dedicated to panel discussion and open Q&A. As always, please feel free to submit questions at any time during the session using the Q&A function on your Zoom control panel. We'll use that Q&A function to collect and respond to questions throughout the session and mostly during the live Q&A at the end. We'll also keep the chat function open in case you'd like to share comments or resources with the group at any time. I also want to note that we are recording the session, and as usual, we'll post the recording and slides on our EHE Regional Response webpage within the next week. So now we'll get started with Leroy Blea, who is the Ending the Epidemic's project manager at the California Department of Public Health Office of AIDS. Thanks for joining us this morning, Leroy.
I'm going to take myself off mute and turn on my camera. Thank you so much. I'm going to go ahead and share my slides. Good morning to you all. My name once again is Leroy Blea, and I am the Ending the Epidemics program manager with the California Department of Public Health Office of AIDS. I joined the Office of AIDS in March of this year to do 2 jobs mainly. The first is be the Ending the Epidemics program manager, succeeding Kevin Sitter, and of course no one replaces Kevin Sitter, but definitely have a chance to honor his work by assisting 6 of the most highly impacted counties across California with their Ending the Epidemic plans and to accelerate the end of HIV in their communities, represented by the membership of this group. I'm also, the other part of my job, the other main part of my job is to focus on the implementation of the integrated strategic plan process, both internally and across California. So I'll be talking a little bit about both those things in the context of our topic today. I'm just going to go to the next slide. So I'm going to be talking once again about community planning that facilitates these programs that help connect people to prevention services and medical care. And then I'm going to be sharing some program examples. I have a lot of program examples, so caveat is I may be skipping from in the context of my presentation to very selected program examples to highlight a few. In particular, I'd like to highlight some of our PrEP programs because California is lagging behind our goal to have 50% of PrEP eligible individuals be on PrEP by our end date of 2026. So I'm going to also talk about resources that will be embedded throughout the presentation. If there's not a resource that you can see, you can definitely visit our website at CDPHOA, and I will also be putting some resources in the chat after my presentation. So I wanted to start by just talking about the context of community planning that's been going on in California. California has been doing a lot of planning over the last 10 years, beginning with our first integrated strategic plan addressing national HIV and AIDS strategy. We've also had a big effort for ending the epidemics planning that included a state HIV ending the epidemics plans in 8 of our phase 1 counties, 2 of those counties on their own, and 6 of those counties collectively in an EHE plan. We now have all Part A HRSA funded, CDC directly funded entities are now required, as you know, are required to have an integrated plan focusing on integrating HIV prevention, care, and surveillance. And California has taken this opportunity, because of all this planning we've done before, to level up by not only addressing the integration of HIV prevention, care, and surveillance, but also to integrate and address HIV as a syndemic with hepatitis C and STIs. So our plan that I'll just talk about briefly as the context of my remarks focuses on, actually my next slide, I'm just going to advance the next slide. The overarching principles of this plan, and you should recognize the cover because we released this in January of 2022. If you don't recognize this plan, then this is a great opportunity to kind of put it on your to-do list to go and review this plan. This is the basis of our integrated planning efforts in California for the next 5 years. This plan addresses HIV as a syndemic with STIs and hepatitis C through a social determinants of health lens. It focuses on achieving health equity and reducing disparities, and also implementing these interventions. I'm going to be talking briefly about the strategies contained in this plan through a status neutral approach, so that people living with HIV and people at risk of HIV and other conditions like hepatitis C and STIs can receive services along a continuum of care seamlessly. And that is the vision of this plan. And this plan focuses on priority populations that aren't as well served, are underreached by traditional baseline services and care. And so I'm just going to pull up the plan in one page. This is a summary of the plan. A note of the plan too, it's a relatively short plan. It's a 30 pages, actually it's about 20 pages. It's on our website, and it's on its own website that I'll list at the end of this presentation. This plan focuses on social determinants of health. It organizes 30 innovative strategies across these social determinants of health. Seems like a lot of work, and it is if we achieve all of these things. I'm not going to go into these things in detail because more information is located on the special website we created for this. And we've been doing education about this again and again and again. But this overall will organize California's work for the next 5 years. And we are, the other interesting thing about this is that some of these strategies, obviously if we achieve one of these strategies, it's overlapping with others. So there's a lot of synergy between the types of interventions that are located on this sheet of paper. This plan was derived from a set of meetings that happened last year. We convened a work group of 25 individuals, and that was augmented by experts across California and across the country that came and suggested the next best steps to addressing racial equity, housing first, healthcare access for all, mental health and substance use, economic justice, and stigma free. They suggested that we address these particular social determinants of health. So we selected these, and the strategies here are also part of their expert advice and technical expertise. We've taken this plan and we presented it to the community at large in California starting in January. We did this in a variety of ways that I'll talk about briefly, but this has gotten a lot of input from and has been very well received across California. And I'll talk about how we've gotten that input thus far. Though it's at a high level, the plan is going to have evaluation and metrics, and this just shows the 6 metrics that are used to evaluate the Ending the HIV Epidemic initiative, and that this will be part of what measures our success in California over the next 5 years. Obviously, HRSA has developed these HIV metrics and intermediate goals to contribute to the overall goal of a reduction of new HIV infections by the end of 2025. You're all well aware of that. I'm not going to spend a lot of time here, except that looking at our indicator of PrEP coverage, our goal is to reach 50% of individuals in California, and we are not close to this goal, and we're not close to this goal particularly for people, Black, Indigenous people of color. So our efforts for this plan and for the programs that I'm going to be talking about today are going to be focused, particularly the special initiatives are going to be focusing on trying to correct the disparity and trying to build health equity. Just briefly about the community engagement that I said that we did some initial presentations to the California Planning Group and other Part A planning bodies. Just to note, other that most of the Plan A planning bodies are joining us in co-authorship. and the two that are not in LA and Orange County are coordinating with us, certainly, and we're very excited to coordinate with all of these and also be co-authors with other Part A's across the state. We had a statewide town hall to over 460 participants. We then turned this into a roadshow and had 17 in-person meetings throughout 5 regions of California, and we had more than 300 attendees to these meetings. We did a virtual input survey, and we had a provider needs assessment that was virtual as well. All of this input has gone into creating a blueprint that helps us drill down into these 30 strategies. This is with our work group and being refined. It's going to be released to another round of community input in December and January. So this is fairly a huge effort in community engagement that the state is engaged in. And you'll notice when you see the plan, we actually invite you to review it and to make it better when it comes out as a blueprint, that there are many, many strategies in there that you're familiar with. Certainly anybody that's doing HIV and AIDS work or syndemic work is doing to some degree social determinants of health work. And so we know many things are going on already. So we're very excited to partner with you going forward, and we're looking forward to more input from you going forward as well. Just to let you know, there's substantial work going on both in the community and at the Office of AIDS that's focused on integrated work, that syndemic work, and we wanted to mention a few examples. The Office of AIDS is engaged with implementing street medicine in 5 of our 6 directly funded through the CDPH EHE counties. Street medicine addresses social determinants of health by actually taking services, rich primary care services, and delivers them to individuals that are experiencing homelessness. And so this is not about mobile vans. It's different than that. This is about delivering a rich primary care model into the community of people living with people experiencing homelessness. And so the Keck School of Medicine is helping us with this. I also want to give a shout out to this group and to Elena, who helped link the State Office of AIDS with the Keck School of Medicine and is now a contractor with us that's helping to directly implement this training program in 5 of our 6 counties. So it's exciting. We're excited to have outcomes from this pilot and demonstration project that we'll be able to share with other jurisdictions. And we invite you to follow our next steps through the OA Voice and our regular updates at our stakeholder calls. I also wanted to mention the Take Me Home program. This is through Building Healthy Online Communities. Take Me Home, the State Office of AIDS offers self-testing, a self-testing tool. This effectively puts integrated screening into the hands of clients. And in a phase 1, we offered OraQuick testing to our phase 1 EHE counties. These tests were promoted through gay dating websites in kind of an automated fashion, and regular data was reported back to public health partners. And in order to connect, to be aware that clients were going to be connecting at a higher level to the services HIV services that are needed locally. In a phase 2, our project incorporated 3-site STI testing, dry blood HIV testing, a PrEP panel, hepatitis C testing to those that qualify. And these STI services are up and running in all of our EHE counties at this point. This is part of the test level and line level data that we've been able to provide to the CDC for ending the epidemic's objectives. I can talk more about the outcomes of that if you have any questions. But I just wanted to announce in a phase 3 of our OraQuick testing, we plan to expand OraQuick HIV oral testing to all counties in California by the end of the year. This means that in any county, in any zip code in California, they will be residents of these counties will be able to order a test through the Take Me Home Building Healthy Online Communities website. This serves adults 18 and older. And these testing services, we believe, are going to be part of a solution that results in more people not only being linked to knowledge of their HIV status, but also being linked to relevant medical treatment for HIV or prevention services if they're negative. And also, I just wanted to note that our STD control branch is joining us in implementation of this plan. They have some amazing integrated projects here I'm not going to do them justice by just touching upon them lightly, but I would invite you to review our plan where we talk about specific examples that the STD control branch is also running that are integrative services. I wanted to touch upon, well, by talking about our services, I wanted to connect you to just an overview of 3 of our branches at the Office of AIDS. I said that a lot of our work is certainly innovative, and that's true, but much of our tried and true work is also part of the solution that helps lead us to ending the syndemic in California. So we're taking the work that works forward with us into our strategic plan and our work that we're doing in the next 5 years, and we want to make that work more effective for people that it hasn't up to this point, people that are largely from populations that haven't been as well served, as I said, Black, Indigenous, people of color. So just to highlight some of the programs in the HIV prevention branch that you are all well aware of. This is just a review, I'm hoping, mostly, but the HIV prevention branch focuses on partly on expanding HIV and hepatitis C testing in an integrated fashion through publicly funded test sites. They also administer the HIV test counseling training program. Their programs are span between focused programs that focus on individual populations like Black MSM, and also they have examples of their programs that they support to expand routine opt-out testing in institutional settings like medical emergency room departments and jails. The device that they use is OraQuick for both hepatitis C and HIV, and the training and technical assistance that is offered as a package acknowledges the fact that this is a big part of the Respond pillar, having people diagnosed and connected to appropriate care. Also, there are some demonstration projects that are part of the HIV prevention branch that I'll just note briefly. PrEP and PEP Navigator projects, the Project Empowerment and Rapid Antiretroviral treatment projects focus by and large on people, Black, Indigenous, people of color, special populations that haven't been well served by baseline services and care. And I have more detail, but I want to make sure I get to the very end of my presentation. I'm just noting that the time that I have. So I'm going to be just going on, and I'll answer questions about these projects if you have additional information or additional questions. I wanted to mention the HIV care branch. The goals of the HIV care branch are to reduce the number of new HIV infections, to increase access to quality of care, and to reduce HIV/AIDS related disparities. So even at its base objectives, the goals of the HIV care branch and Ryan White programs have always been aimed at our getting to zero objectives. I will name just a few programs. The first 2 programs that I'll mention the AIDS Medi-Cal waiver program because it's a strong program that focuses on connecting individuals to case management services that keep them out of institutional care. So people living with HIV that want to live at home can live at home with medical case management services. We have 20 providers across the state of California, and the eligibility for this program is on our website, but individuals must have an HIV/AIDS diagnosis, and they must have the status to make home care appropriate, and they must be Medi-Cal eligible on the date of enrollment, and have been certified to meet nursing level of care or higher. But there's a great advantage to keeping people out of institutional care, and we are looking to actually incorporate any and all ways the national AIDS health strategies, new indicators of quality of life. So this is one example of a program that definitely meets that test by keeping individuals out of institutional care and at home. I'm going to mention the HIV care program, which is just another way of saying the Ryan White program. California is funded through Part B. The HIV care program is part of a comprehensive system of care that includes primary medical care, essential support services for people living with HIV who are low income, and also seeks to improve the quality, availability, and organization of HIV healthcare and support services throughout California. There are an amazing amount of services. I was just reminded of this when I visited a housing learning collaborative that just compared HOPWA services versus Ryan White care services. There are an amazing array of supportive services associated with Ryan White care. They act by and large to bring people into care as well. And this serves well over 15,000 clients a year throughout California. And the services are definitely customized locally, given the local plans for Part A's as they build these programs out to serve the unique needs of EMAs and TGAs in California as part of that. The eligibility are similar, being a person living with HIV, being low income, residing in California, and there are a lot of services. It's a rich set of services that can be offered, and I'm going to leave it there, but leave you to do more research on our website that gives more detail about exactly what this serves. I just want to also mention briefly, there's the Housing Plus program, which is we have a demonstration project here, and this is focused on connecting more people of color with Ryan White Care Services using a shallow rent subsidy and rent subsidy for making housing effectively an intervention for health outcomes. And we want to do that more. In our HIV, our strategic plan, we have housing first as one of our indicators. We're looking for more opportunities to think about how housing can be an intervention, and vice versa for health, and health can be an intervention for housing. More about that. If you want to know more information, I'd love to talk to you more about that. The AIDS Drug Assistance Program, I wanted to mention a couple programs, but mostly detail our PrEP program. So the AIDS Drug Assistance Program branch administers both ADAP for people living with HIV and also the Pre-Exposure Prophylaxis Assistance Program, the PrEP app, for HIV negative individuals. So this is a great example of like how we integrate services at the Office of AIDS in order to provide an administered status neutral program. So we have a lot of overlapping initiatives that overlap with the AIDS Drug Assistance Program and the prevention branch, and with other branches in the State Office of AIDS. We want to expand the way that we're doing this integration going forward so that clients really see a seamless service, whether they're a person living with HIV or a person at risk of HIV. These programs can be served seamlessly at single points of contact. We want to see more and more of that. So I want to talk briefly about, well, I'm just going to move on. We have AIDS Drug Assistance Program certainly helps to ensure that people living with HIV in California who are underinsured or uninsured have access to medication. ADAP pays for the prescription costs of medication on the ADAP formulary for eligible individuals. I just want to say that ADAP formulary is rich. California has invested a lot in making the ADAP formula broad and wide because we know that the policy outcomes of the ADAP program are enriched by a rich formulary to give people more access to more medications on the menu of things that will keep them healthy. Also co-pays and insurance premiums are eligible for payment for qualified individuals, and I certainly invite you to visit our website to get more information about that. So the AIDS Drug Assistance Program, well funded in California, really does link us to our EHE goals. I wanted to just touch upon a few other programs that are particularly focused on PrEP. So we talked about our PrEP AP program or PrEP app program. It offers, we ensure that all of our enrolled clients have access to medications, both PrEP and post-exposure prophylaxis. So it's both PEP and PrEP, as well as medications for the treatment of prevention of other sexually transmitted infections, the rapid initiation of antiretroviral therapy for enrolled clients who test positive for HIV as well. We also cover the cost of testing for HIV, renal and liver function tests, STI testing and pregnancy, and medical services related to PrEP, such as office visits and provider-administered medications. One important thing to note is that in most cases, this is the payer of last resort, which means that we require our clients to exhaust the benefits of other insurances if they have that, or other third-party insurance pharmaceutical assistance programs before utilizing these benefits. And those details too, in a very client-centered way, are on our website. So I refer you to that for more information that is both tuned to both providers and clients. And can I get a time check just quickly?
Yep, Leroy, we're at 1 more minute.
Okay, so I'm gonna just rapidly go through the fact that we have mapped these sites throughout California. I recommend that you visit on behalf of clients and on behalf of yourself. where these enrollment sites are. We just like you to note that there are different types of services offered through the PrEP program. We have a temporary coverage service and a immediate access service designed to bring people rapidly on PrEP. I can talk more about it in our question and answers, but by and large, these two programs we're excited about. They're an expedient way for people to start PrEP or PEP. And they were developed in response to needs that we saw to take advantage, first of all, to some of the legislative changes for PrEP, like SB 159. And there are specific ways to access this program through our network pharmacies, and we have that well mapped at our website. So I wanted to just thank you very much for your attention, and I invite you to follow our progress and get more information at the websites embedded in this presentation. I also invite you to follow our progress on our strategic plan. I've included the link here, and of course my email as well. If you have any questions for me, feel free to reach out.
Wonderful. Thank you so much, Leroy. You covered an amazing amount of ground in this limited time. So thank you. Really appreciate learning about the innovative work going on at the state to help support access to HIV services. If folks on the line do have questions for Leroy, please feel free to submit them at any time using the Q&A function on your Zoom control panel. And I will also be sharing the slides and recording after the session. So if anyone wants to review the information that Leroy shared or click on some of those links in the slides, you will have access to that after the session. And next up, we have a presentation from Megan Crowley, who is the HIV project manager for the Alameda Health Consortium. Welcome, Megan.
Hi there. Good morning, everyone.
Good morning.
So can you see my slides okay?
That looks great.
Great. Okay. So thank you, Elena. So I'm Megan Crowley. I'm actually now Senior Program Manager at Alameda Health Consortium, which is the regional association of federally qualified health centers here in Alameda County. And in addition to my role at the consortium, I'm also on the Oakland TGA Planning Council and the steering committee of East Bay Getting to Zero, though today I'll be speaking about HIV access. So I'll talk about our program's background and structure, and then highlight several of our strategies for improving access to care for people living with HIV in Alameda County. So this is our collaborative network. We call ourselves HIV Access, and we're made up of my organization and 4 federally qualified health centers and 1 public hospital. Some of the assets of our collaborative network model include diverse staff, lots of opportunities for collaborative learning, training, and projects, and many access points throughout our region. Our program was founded in 1992. We are a recipient of Ryan White Part C funding through one of our agencies, Bay Area Community Health, who I see is on this call right now. Our mission is to provide coordinated, comprehensive, high-quality primary health care for people living with HIV, with the goal of ensuring early access to treatment, mitigating health disparities, and reducing the spread of HIV. We currently serve a little over 1,300 clients, constituting a little over 1/4 of people living with HIV who are in care in Alameda County. All of our agencies provide a combination of primary care, case management, behavioral health, oral health, substance use treatment, and medical nutrition services. And all of the clinical agencies are funded by combinations of Ryan White Part A, B, C, and D. So just looking at our region on the map, you can see this is Alameda County, and you can see clinical sites spread throughout our county, although many are focused in the Oakland area, which is sort of the focal point of the HIV epidemic in our county. In terms of demographics, 83% of our client population is people of color, including 42% Black and 31% Latinx. We're about 3/4 cisgender male, 20% cisgender female, and 4% transgender, and about half of our clients are over 50. Just looking at our care continuum, I think we've been doing pretty well on most measures throughout the pandemic, in particular linkage to care. We would like to see some improvement on our viral load suppression measure, although I'll note that probably about half of the people not confirmed suppressed are actually overdue for labs, which is partly a function of pandemic related challenges. So I just want to highlight one project we've worked on to start. So back in 2019 and 2020, we were recipients of a Ryan White Part C capacity development grant focused on linkage and rapid ART. A major focus of that project was improving coordination between Alameda Health System, which is our county's public hospital system, their HIV clinic, and their routine HIV testing program in the emergency department at Highland Hospital. At the time, 30-day linkage rates were way lower at Alameda Health System than they were at our community health center sites, primarily because most of the linkages were coming from the ED, which tends to be a population facing a lot more barriers to linkage and to care. So this is an analysis the linkage team at Alameda Health System conducted back in 2020. They found that the vast majority of unlinked clients had multiple barriers to linkage and to care, including 6% with substance use disorder, more than half didn't have phones, and about 1/4 had one or more mental health diagnoses, and over 10% were houseless. So we worked on improving coordination between the ED testing program and both the HIV clinic at Highland Hospital, as well as our other clinical agencies in our network. And we did see 30-day linkage rates improve to 85% as of this year. So a lot of that effort in streamlining, warm handoffs and coordination has really paid off. Another project that we've worked on simultaneously is our Rapid ART initiative. So we began this work back in 2017 and started formally tracking our data for Rapid ART in 2018. We implemented several different activities, including developing a shared definition for Rapid ART, which is a prescription within 1 business day of first in-person contact with the HIV team. It doesn't have to be a clinician, it could be any team member. And we did make that a little more flexible during COVID, since a lot more people were engaging virtually during that time. And we decided to focus on the first contact with the HIV team, primarily because we do not have control over a lot of other factors. Unlike some areas like San Francisco, we do not have countywide infrastructure for Rapid ART, for data or staffing for those efforts. So we really decided to focus our efforts on what is happening once the HIV team knows about a newly diagnosed patient. So other activities included creating a linkage tracking sheet, which is used by all of our member agencies, Rapid ART protocols and workflows that are tailored to each clinic, and then clinic level interventions to address structural barriers. So that might include prescriber coverage on days when there's no HIV clinician on site. And then, our our team worked with each individual clinic team to problem solve individual and systemic barriers as a team and as a network. And so since 2018, we've managed to bring our rapid ART rate from 56% to 95%, which is far more successful than I think we ever would have expected. So just to give you a little snapshot of the before and after. So this is sort of a summary of what linkage looked like before we started our rapid ART initiative. So, you know, often the whole linkage process took up to 90 days or more and had 8 or more steps. Often, you know, the steps, you know, were separated by many days, and things that, you know, could have been more patient-centered by, you know, happening on the same day in the same location were broken down. It was really much more provider-focused than patient-focused. And then this is a summary of what it generally looks like with rapid ART, which is sort of consolidating the different steps in the process and trying to, you know, streamline moving from one step to the next, doing as much as possible during that first day after confirming the new diagnosis. Other access to care activities we've worked with the clinic teams on include, you know, ensuring direct access to linkage navigators via work cell phones. So that's, you know, making sure other agencies are aware of the direct contact at each clinic, as well as, you know, potentially new patients, protecting HIV provider drop-in slots to, you know, make sure folks can get in sooner. Also having a HIV provider on-call schedule at some of our clinics, or training primary care providers at those clinics to provide backup for rapid ART starts on days when there's no HIV provider available. You know, also offering hybrid in-person linkages with navigators and virtual provider visits to, you know, make sure folks can get their prescriptions, even if the providers are not on site. And, you know, the HIV teams at each agency, you know, taking the lead in, you know, making sure the other primary care providers at their agencies are, you know, doing routine HIV testing and, you know, understand the urgency of linkage to care when someone has a positive result, and also who to contact when that happens. Another example is work that our medical director, Dr. Sophie Wong, did with one of our agencies in strengthening outreach for people experiencing homelessness in our county over the last couple of years. So one of our clinics, Lifelong Medical Care, operates a clinic site called Trust, which focuses on providing drop-in access to people experiencing homelessness. They're also funded by Alameda County Healthcare for the Homeless to conduct street outreach. So while Lifelong has been part of our network for many years, the Trust Clinic was integrated into the HIV access program shortly before the pandemic, which means they're now part of our quality program and our data. With data feedback and tailored technical assistance from our medical director, Trust was able to nearly double their viral load suppression rate over the course of about 2 years. Additionally, they've been able to maintain very high linkage rates despite the additional barriers faced by their population. We also put a lot of effort into looking at equity and reaching priority populations in our network. Every other year, we conduct a comprehensive disparities analysis on our retention and care and viral load suppression measures. And each clinic team in our network conducts at least one HIV quality improvement project each year. Often these projects focus on a disparity or another gap in the care continuum. So as an example of, you know, how one of our clinics worked on improving access to care, based on looking at disparities data. One of our agencies, La Clinica, learned that their cisgender female patients had much lower viral load suppression rates than the rest of their patient population. They hypothesized that this was because many of these patients have young children, and La Clinica also didn't really have dedicated programming for this population, unlike the majority of their population, which is made up of men who have sex with men, and they also have a transgender program. They implemented several interventions, including Saturday clinic sessions with childcare. And the project is still in progress, but they have updated us that several previously unsuppressed patients, had their most recent viral loads under 200 at most recent measurement. Moving on to, broaden our view to regional collaborations. Our network was deeply involved in the development of the East Bay Linkage and Retention Network, which started back in 2011. And eventually it was, one of the groups that evolved into our East Bay Getting to Zero collaboration. So, now we really have a great regional structure for improving access across the East Bay, which includes both Alameda and Contra Costa counties. We are well represented on the East Bay Getting to Zero Steering Committee. All of those blue circles on the steering committee are staff or clients of our member agencies. These are the strategic priorities of East Bay Getting to Zero, which we're very involved in. All of these components are connected to access to care. Key activities we've been involved in for collaborations in our regions include making improvements to our regional directory of services for people living with HIV or at risk for HIV in our region, participating in local events and developing resources for providers in the community. We've also been part of various workshops, including a workshop on collaborations with the emergency department and substance use programs, and a recent workshop on housing. And just, noting what I've already mentioned earlier, the improvement in emergency department linkage rates and also our rapid ART rates over the past few years. And finally, I just want to, mention that we've also had various collaborations directly with the Alameda County Public Health Department. We work with them on their annual Ryan White client survey. We have a process for implementing data to care activities between our member clinics and the county's HIV surveillance team. We, on a quarterly basis, share our quality management data with the county to, minimize double reporting for shared, all of our HIV access agencies are also Ryan White Part A agencies. So to minimize double reporting, we share data. And, we've also worked with them on rapid ART activities starting in 2017, as well as the Healthcare for the Homeless program. And that's all I have. This is just a photo of our network shortly before the pandemic. I hope we can get together in person soon to update our group. And that's it. Thank you so much.
Wonderful. Well, thank you so much, Megan. I really love, I think Leroy kind of mentioned this in the chat too, but I love what you highlighted about the power of a collaborative structure of organizations that can really work together to help ensure community members are getting the services they need. So thank you so much for sharing with us.
Great.
I'm already seeing a few great questions coming into the Q&A box. Again, feel free to add questions there at any time for our amazing presenters. And now we're going to transition to our final presentation this morning. We have Kim Bui, Section Manager of Direct Community Services with the Los Angeles County Department of Public Health, Division of HIV and STD Programs. Thanks for joining us, Kim.
Hey, good morning, everyone. Okay, I actually think this is a really nice segue. We've covered a lot of really kind of broad topics. Here, I really want to kind of hone in and focus in on kind of what it looks like to implement a rapid program, and hopefully I can kind of expand on some of what Megan and Leroy have already covered. So again, my name is Kim. I'm the section manager here at the LA County Department of Public Health, Division of HIV and STD Programs. We are pretty large. As you all know, we have a pretty large health jurisdiction. So here we have all of our testing and navigation programs under one kind of unified unit. One of those programs, though, that I oversee is the pretty new Rapid and Ready Navigation program. I admit we are a little bit later to the game to rapid start, but we are here now. It's been in effect for about a year, but I would say it's really been hitting the ground running for maybe the past 6 months. So I'm really here to kind of just show you what it looks like on the ground, kind of what we've learned. I see some of our LA County partners here, some of our clinic partners here, so happy to see y'all. We are still working on kind of our data evaluation and outcomes, but I think that there's a lot really to be said about what it looks like. So I always like to put a face and a name to our hardworking staff members. So we are a small and mighty team of 3 health navigators. These are the folks that are, taking in the referrals. These are the folks going out to the clinics. They're doing all of the very important work that we, are all here to do. At this point, I would say, we have positioned ourselves, of course, to really be a sort of safety net and to sort of fill in the gaps where, some of our other linkage programs perhaps might not be reaching clients out in the community. So to expand on what Megan has explained earlier, we're really here to try to connect with folks, try to get them in, try to get them on meds as soon as possible. And the way that we've sort of designed this is we've sort of designed it as a sort of 2-prong effort. So the piece that I oversee is really the navigation team. The other piece that is very critical to the success of this is, of course, our clinic partners. So what we've done is, we have about 45 HIV specialty clinics here in LA County. We were able to onboard 8 of those sites who really just agreed to sit down with us, meet with us frequently, really agree to implement rapid protocols, really agree to kind of set up systems in place so that we can see some success. And ultimately so that we can work together once we kind of start that linkage process. Over time, we always kind of check in on both ends, on the navigation end and the clinic end. My colleague, Becca Cohen, is always really great at being that key person to kind of talk from the provider to provider level. And we are always sharing ideas between herself and me and also across the clinics. We are constantly checking in and kind of reevaluating, where can we continue to assess kind of capacity at the clinic level, capacity on our level. We are engaging and really encouraging a lot of one-on-one sort of learning collaborative meetings, trainings, and also phone calls to kind of see how things are looking on the ground. And so this takes me to a diagram here where, I really wanted to showcase that while we have these HIV specialty providers, we do realize that we have a lot of non-HIV specialty providers who are doing HIV services such as testing. So we really positioned ourselves to kind of try to work more with those non-specialty sites. So here, I think I want to highlight the EDs because I know that we've talked about that. We definitely work with mobile testing units. We will work with any other provider who perhaps is running a test but doesn't know kind of where to go, what the resources are, where to turn to. From there, of course, we are always going to try to get them to an HIV provider that makes sense, whether that means in a geographic sense, whether it means from an insurance standpoint. But we are really trying to pivot them towards the specialty rapid ART hubs that I mentioned earlier that we onboarded. So really this program is really intended to try to fill the gaps, as I said before. And so it's for anyone who tests positive from any provider. It's for anyone who's interested in seeing an HIV provider. So here we're talking about folks who might be out of care, who just need sort of some help or some kind of resource. If someone has moved here or if they're thinking of moving here, we can certainly take those referrals. So we really are here to focus on, again, the testing sites. We're here to kind of help any FQHCs, community clinics, medical centers, hospitals, and we're really trying to partner with the EDs. Aside from that, we certainly work internally. So we work pretty closely with our internal partner services section, which are our DIS workers. We are working with internal mobile testing units here. We have actually worked with some Take Me Home referrals also. So we're just here and we're ready to take on basically anyone who hasn't already been serviced by another program. Some of what the health navigators are really positioned to do is, they really spend a lot of time out in the field. So we are here to kind of look for folks, whether they live in an encampment, in an apartment, in some kind of other residence. We certainly have our own transportation services. So we have rideshare benefits through Uber and Lyft. We can always try to help troubleshoot any insurance benefits. And we pretty much always try to attend the first appointment, meaning we kind of take them there. We make sure that they get into the ride if we are kind of coordinating that. We sit with them through the appointment. We ask if they would like us to step in with them into the medical exam room. We're basically just here until folks say that they don't want us here. Aside from that, we, as best as we can, we're offering any psychosocial support in addition to any medical coordination staff. So if there are social workers there, we might work with them there. And we are here to kind of bridge any referrals that the clinics either may need some assistance following up on also, or any external referrals, maybe for cell phones or maybe utility bills, things like that. And we really try to, on a case-by-case basis, we try to ensure that folks are undetectable at the end of our work with them. We try to make sure that they are having kind of their basic needs met, basic meaning, they're kind of satisfied with their medical provider. They are satisfied with any referrals that they need at that moment. But we always keep an open door. So even though we are a fairly new program, we've already seen some returning clients, and we're happy to see them back. Just a couple of examples here, just to kind of paint a picture of what a scenario might look like, kind of post rapid implementation versus prior, which I know that Megan has kind of alluded to. One of our successes is a 36-year-old Latinx male who was a new diagnosis, who we actually got from our internal partner services unit. So we got that referral on a late Thursday, and we were able to get them an appointment. We were also able to get their partner an appointment within 3 business days. So that was pretty exciting. We needed to get them HIV treatment, syphilis treatment, because we had a strong point of contact, strong meaning, a person who was designated for rapid linkage. It was very seamless. It was very seamless. We got them transportation there. We sat through the appointment. Everything was great, met with the provider, got ART, received syphilis treatment. And again, what I wanted to highlight here is sort of what Megan was describing earlier, where, some of these processes can take minimum 2 weeks, at most, maybe 90 days. But here we were able to do essentially everything within 3 business days, which was great. On the flip side, I just wanted to paint a picture of maybe what it looks like to not have a rapid point of contact in place on the clinic end. So here we had a 22-year-old African-American male, also a new diagnosis. This was an internal referral from our mobile testing unit. When we got this referral, we certainly did our best to get them into an HIV specialty provider. This particular client, because of where they were geographically located, they chose to go to a provider who wasn't part of one of our rapid treatment hubs. So of course we had to kind of troubleshoot the Medi-Cal being connected to another county. Even getting kind of that linkage process started was a little bit tricky on our end. You know, there were a lot of emails back and forth, a lot of calls back and forth. This client in particular was kind of having trouble organizing themselves. They were in school, they were working. So I think, you know, that there was a lot of effort to just try to get everyone on the same page. But, you know, after about a month, we did, you know, successfully transfer that insurance over. We did eventually get them to meet the provider. We did eventually get them on meds, but we still had a little bit of difficulty kind of just streamlining these services there. However, you know, all is still well. We did confirm that this client was able to reach an undetectable status, so still a success at the end of the day. Having described those two kind of scenarios, I really just want to bring home the points of, you know, kind of what we've learned works for us and what we have really tried to verbalize at our clinics. So we have always asked for a strong point of contact, meaning, you know, we don't want to be bogged down with, you know, calling the front desk who, you know, may not be kind of familiar with rapid art or may not be familiar with kind of the importance of rapid art. So having a person that is specified towards linkage and more specifically specified towards rapid linkage has been critical and has been successful so far. Of course, having an open communication between the navigations and the clinic teams. Right now, we are thankful enough to be able to position our navs to essentially have a warm line available so that if anyone calls, they can reach any of our 3 navigators. We also have a shared email account so that if anyone emails that, somebody can pick it up, I can pick it up. And we have asked for the same at the clinic implementation side. So we've asked for kind of a shared number in case somebody is out. We've asked for a shared email account, and that has been successful so far. Of course, it goes without saying appointment availability, meaning, you know, within the week, ideally, you know, within a day or two, also very ideally if the client wishes. And, you know, I really can't stress enough how important it is to have front desk staff who are knowledgeable about the rapid programming goals. You know, from a customer service standpoint, we've had over the years, not just through this program specifically, but we've had instances where we've linked someone and they may have not had the best experience with the front desk staff. Now, we certainly understand that there are, you know, a lot of co-occurring priorities at your clinic level. We're very aware of that. I think the point here is just that we want to make sure that as best as we can, we want to highlight the importance of having everyone, regardless of the level of staff at the clinic, kind of be aware of what these goals are, just in terms of, you know, having a good experience for the client. Of course, another key to success, really the kind of major point here is having meds or starter packs issued at the initial visits. We also understand, you know, this varies from clinic to clinic, and within clinics, it varies from provider to provider. But if a pharmacy is on site, of course, we would love to see meds delivered the same day that the person is there. If there isn't a pharmacy on site, we've had good successes with pharmacies kind of delivering starter packs through the clinics indirectly. So on the flip side here, of course, I think it just makes sense. Having a non kind of specific point of contact, we have seen in real time how this kind of can delay linkage to care. Appointment availability, of course, we understand that different clinics are dealing with other issues, but that of course can delay kind of the ability for us to connect with the person and engage them when they're sort of willing, once we kind of have them in front of us. And again, you know, we've encountered some instances where maybe a provider is on vacation or they're out, and so maybe the provider that is coming into the clinic is not trained on rapid, or perhaps, you know, isn't of the mindset that they want to deliver meds without seeing confirmatory labs or without having more appointments kind of confirmed. And of course, as I've mentioned, the front desk staff. So really to wrap this up, you know, over the past few months especially, we've really been trying to ramp up the capacity assessment piece. So we've been holding more sessions on, you know, all of the concerns that the clinics have at that level. We've been trying to address insurance concerns in terms of billing. We've been trying to message out that we would like to see everyone, be able to get an appointment, be able to get meds, regardless of insurance status. But we do know that there are realistically concerns about, kind of what that looks like. So we've been holding those types of sessions, those types of focus sessions. As I've said, the learning collaboratives and coaching sessions are ongoing. The first cohort right now, we are wrapping up, I believe, in January, and then we are going to set out to onboard another set of clinics for a second cohort. And for any folks who might need this resource, any folks who are either in LA County that maybe perhaps are not an HIV specialty provider, or maybe just needs this resource, again, our warm line here that's listed on this page, this will ping any of our 3 navigators, and that rapid email account I monitor and our 3 staff members monitor. So this information we really are trying to push out into the community. We have put it on our website, so I know that some folks have kind of found us that way. We have put them out in flyers. We've met with some of the EDs in our county, and we are trying to push those out within those networks. So we're really in an exciting place where I feel like we're new, but we have our systems in place and we're ready to just kind of see where this takes us. And that's it for me.
Great. Well, thank you so much, Kim. Thanks for sharing your innovative Rapid and Ready navigation program with us. So now I'd like to invite Leroy and Megan to join us again for a bit of panel discussion and Q&A. And as they do that, I'm just going to remind folks that you can still submit questions in the Q&A if you'd like. If you have questions for any of our presenters, feel free to use that, that separate feature there on your Zoom control panel that says Q&A, and you can submit your question right in the Q&A box. So we're going to start with a couple of questions that came up commonly during registration from participants, and then we'll move into some open Q&A with participants on the line with us now. So one thing that participants regularly kind of asked about during registration was, what were some key barriers that you are currently seeing regarding access to HIV services? So Leroy, maybe starting with you, what are some of the key barriers you're seeing across the state that you think are really at this point hindering community members from accessing the HIV services they need?
I think we're still dealing with a COVID correction and now an MPOX correction for the context of services and service delivery. Many of our programs and program members have still been redirected. So I think, this is a bit of a skeptic in me for taking a look at the drop in HIV infection rates that we've seen during this period of time, thinking that it may be related to just less testing. So I am looking forward to getting back to normal as normals can be. And instead of actually being kept from doing these programs, but learning from how we can actually do more with the information that we've gotten as part of implementing COVID response, leverage more of the workforce that was developed for COVID response into our programs, because there really is a dearth of individuals that we have in these programs. We're talking about like a small but mighty team. They sound amazing, Kim, but we have, and also I know Megan, your team is amazing too, but we have staff and programs that have no capacity to have surge because they're just so limited in staffing. And that really interferes with the idea of rapid response. And I think that would be having a workforce development plan that really kind of ramps up many of the depth of the staffing that we have across the state for these programs.
Thank you, Leroy. Kim, how about for you? What are some of the key barriers that you're seeing here in LA County that you think are kind of hindering community members from accessing the HIV services they need?
I'm definitely seeing on the ground level, at the clinic level, kind of what you're describing, Leroy, with, just staffing overburdened. And so we always try to be sensitive to that. We're not really here to be pushy. We're just here to be, advocates in the best way that we can. So we have seen, actually, specifically, we've seen some of our linkage folks kind of get moved to either testing efforts or MPOX efforts. And of course, that impacts kind of how we are able to operate. That impacts, of course, our ability to contact our point of contact. It impacts appointment availability, things like that. Insurance, as I've mentioned, I think that it's just like a cultural kind of barrier that we need to move kind of on and move towards, I think, slowly and carefully, because I think anytime insurance and insurance coverage is brought up, you know, I do understand kind of the hesitation there. So we are working through that actively. I think aside from that, you know, again, because LA County is so large and because we have so many providers, you know, it's hard to right now say that we can just as a blanket statement say that, you know, all providers in LA County sort of should adopt this rapid model. We really are almost pushing to have this sort of mechanism be adopted, but we're just having some struggles there just because, you know, we want to work with providers, we don't want to work against them, but we want to get them on our side too. So that's kind of been an ongoing struggle, but that's where kind of the onboarding process comes in. We're hoping that, you know, as we start to onboard more providers, you know, as we bring on more cohorts, you know, this will kind of just be the new norm. How quickly will we get there? I think we still have to see, but yeah.
Thanks so much. Megan, how about for you in Alameda County? What are some of the key barriers you're seeing?
I'd say workforce is the #1 barrier we've seen. You know, just I've been with our program for 10 years now. And, you know, I noticed that often before the pandemic, our HIV teams tended to be a lot more stable than a lot of the health center teams in general, I think because of their deep connection with the patient population. And I think we've seen that weakened a bit during the pandemic as folks have been, you know, more spread thin and overwhelmed, and, you know, nursing staff get pulled into COVID and all of that. Also, you know, our county has only 2 public health investigators assigned to assisting with linkage and retention efforts. And, you know, for most of the pandemic, there was only one, and she had been pulled into COVID. So even though we are not the county, our teams sort of rely on the county staff as sort of an additional line of support where they have some, you know, capabilities of trying to find people that sometimes our clinics just can't. And when, you know, they have responsibility for so many people and just don't have the bandwidth, you know, we're left, you know, with some out of care folks or folks who are unlinked without that additional line of support to find them. Also, I'd say lab access has been a challenge. A lot of the Quest locations have sort of reduced their hours, and, you know, especially when, you know, nursing staff is so limited, it can be really hard to do blood draws on site. And, you know, folks often don't want to wait at Quest, or they, you know, that kind of thing. So we see, you know, that sometimes delay other steps in the process, or, you know, make it unclear whether they're actually virally suppressed, that kind of thing.
Thank you. Thank you so much. And I also wanted to highlight a comment from one of our participants in the chat too, that homelessness and compliance are really big barriers as well, you know, from the community member or client perspective too. But, you know, really appreciate all of your comments on this question. And I think it seems like, you know, the workforce capacity component remains a huge barrier that all of you highlighted. I'd like to move to another question that came up commonly in registration. A lot of participants were wondering about your recommendations for supporting newly diagnosed individuals. So, you know, what strategies and approaches would you recommend to help support newly diagnosed individuals to process their diagnosis and then, you know, ultimately get engaged in care? Maybe starting with you, Kim, can you share any recommendations with the group?
Yeah, definitely. So, you know, with a new diagnosis, we always try to tread carefully because we sort of anticipate a lot of sort of emotional support there, a lot of health education there. So thankfully, our team is really positioned because they have a health education background. And again, they're positioned to spend a lot of time out in the field and at the clinic, as I said. So I think giving the kind of time and space, and maybe giving perhaps more time and space for those folks to really, meet them wherever they are housed, if they are housed, to really sit with them through their appointments, to really recap the appointments with them, to do a lot of phone check-ins, text check-ins, and to really, really, really follow that case almost until the client verbalizes that they are okay. I think that's what we have been implementing. So, we of course have seen folks, cry in front of us. We have a lot of moments where, there are just hard conversations to be had outside of kind of like the clinical aspect and sort of like, what does this mean and things like that. So I think just being that emotional support, that psychosocial emotional support, in addition to the clinic and sort of separately from the clinic, has been really critical.
Thanks, Kim. Megan, how about for you? Do you have any recommendations for the group about kind of helping to support newly diagnosed individuals?
Yeah, I think two things. One is, trying as much as possible to ensure the HIV team is looped in as early as possible, ideally before the disclosure of the positive result even happens, so that the team can either be on site or available that same day, and can even sometimes coach the primary care provider who was the person who ordered the test but may have never delivered a positive HIV result before, to sort of help them through the process. So making sure PCPs are really aware of the resource of the HIV team from the very beginning. And also having sort of a whole team approach. I think what we've seen is that when patients feel like they can only rely on directly contacting their clinician, then it's going to be a lot harder to connect with someone when they need them. So, making sure that they're sort of understand that the whole team is there to support them, and that, they find the person who can best engage with the patient to, be the person available to them. So sometimes it's the clinician, but sometimes it's like the front desk staff, who might connect the most. And so when you're trying to link someone in, just making sure that they, feel like they can reach any member of the team and everyone is there to support them. And also I think rapid ART is a really important way of engaging newly diagnosed folks, because I think what our teams, I'm not a direct service provider, but what our teams have shared with me is that giving someone something they can do like right away when they learn they're positive is, I think goes a long way to making sure someone feels like they're supported and that action is being taken right away. And, not assuming that they need to like take time to be ready for treatment, just, offering them that right away as though it's, just the standard.
I'll just echo the comments from Kim and Megan, and I especially like the idea of prepping staff to actually do a really good job with the best job they can with the disclosure. And HIV is still a relatively rare condition, relative to other conditions, and so disclosures HIV of a person's positive status happen infrequently. And so I find that in many years of doing HIV test counseling that it helps, and being a manager in clinical settings, that it helps when we drill like how to do it. We do role plays, we talk about processes in a little bit in staff meetings, so that there's little parts of the process always talked about, like, oh, do you remember how to do a linkage? Do you remember that, on the first day, there's just a lot of client support, and we have all these systematic components that are set up so that we can, wherever a client's ready to go on that first day, we're ready as well. The state of California, through its demonstration projects focusing on rapid ART, stress the idea that that initiation happens with a lot of client support initially, that this is done flexibly, that we have follow-up appointments that are done, like if possible on the day. So there's for staff and for the client, there's kind of a path when they can think about it more, like on day 2 or 3 or 4 the next week, that medical case management is an important part of the services that are offered. Also that U equals U education is kind of like a standard both in pre and post-test counseling. And I think that that even, you know, talking about partner services kind of in doing HIV test counseling is something that I think is an art that's coming back, right? It's a great service. It's a good thing to suggest. It's a great thing to talk about status neutral services so that, you know, we routinize being able to do prevention or a treatment depending on what the response is. But it's still, so well-supported staff and a well-supported client, being able to set up a customizable next steps on their own time.
Yeah, thank you so much. I think that really wrapped up the responses so well, Leroy. I've kind of well-supported staff and well-supported clients. And I also just want to highlight, all of you have really spoken to the importance of timely engagement in care. Obviously, you know, Kim, your program is very much focused on this kind of rapid navigation, but I love how each of you highlighted the importance of really getting folks engaged as soon as possible, at least in kind of knowing what's available to them, and then hopefully really being able to connect them immediately to the services they want and need. I just want to go to one additional question from the registration, and then we have a few questions coming in from our audience members today. This question is about strategies for streamlining linkage to care. So we got a couple of questions from registration that kind of ask how you all are working towards streamlining the linkage to care process. So maybe Megan, starting with you on this question, can you say a little more about how HIV Access and the Alameda Health Consortium is kind of working to streamline the linkage to care process?
So the process is sort of, you know, tailored for each individual. Each of our agencies is an independent organization and they have their own workflows, although there's, you know, many similarities. But I think that, you know, in this sort of, you know, we have this sort of more mature linkage program at this time. And I think in terms of maintaining our high linkage rates, we have our agencies every quarter when they provide their linkage data, which is manually tracked due to the small numbers and sort of incomplete, you know, EHR data. When they have someone who was not linked within 30 days and or did not receive rapid ART, they provide a case summary. And so we are able to review those on a quarterly basis. Usually it's just a small number of people who, you know, weren't linked or didn't get rapid ART, to identify whether there was anything that, you know, could have been done either within the clinic or outside of the clinic to have, you know, closed that loop. So one example would be, you know, we saw, you know, a number of case summaries that was like, oh, this other FQHC that is not, you know, is not in our HIV access network because they don't have an HIV program, you know, they weren't really referring people very quickly. So they were doing referrals like they might do a referral for, you know, a much less urgent specialty, you know, need. And so it might be 2 or 3 weeks before the HIV team even learned about them. And so we have been able to, you know, connect with those other outside agencies to, you know, make sure that, you know, they understand the urgency, but that they're also, you know, potentially can work out a more streamlined process with their, you know, the most common clinics they refer to, so that, you know, they know exactly who to call and, you know, how quickly. Does that answer the question?
Yeah, absolutely. Thank you, Megan. Kim, how about for you in your program, kind of what strategies have you all been using to try to help streamline linkage to care?
Yeah, so there's a few ways. So again, we have tried to position this rapid program to work sort of alongside with and almost pair up with our other existing programs. So as I've mentioned, you know, if we have a partner services case that's a new diagnosis and they're unable to find them, we will kind of take a second look. Or if there's a case through partner services, for example, that need some extra hand holding, you know, we can tag team in those instances. You know, I've mentioned we work pretty closely with our mobile testing unit. You know, they, of course, they specialize in testing. They do some kind of limited navigation, but if there's a need to kind of put another team on that, then we can work alongside them as well. We also have a specialties sort of linkage program for pregnant folks. So if we have someone who is just of extreme public health high emergency, then we can certainly pivot that towards another internal team. And of course, we can share data across our own teams. So that's always helpful. In terms of streamlining the process just for us at the rapid level, we really strive towards kind of the perfect scenario where, let's say, an HIV testing provider has just disclosed. That person is still in front of them. They call our warm line, they get a navigator on the phone, and we do a quick assessment and we call the clinic right there and then. We do a 3-way call. We set everything up. We see, you know, how soon of an appointment we can get, you know, kind of what's feasible for the client. And we just sort of do it all at that moment. That, of course, is an ideal scenario. It doesn't always happen, right? Because people leave or, you know, it may be a different type of referral. But whenever we get those sort of opportunities, it has always been great because it really feels like everything sort of kind of synthesizes all in one moment. And it feels very like, yes, here we go. We're going to do it. And then I would say on the clinic level, I sort of mentioned this before, that kind of like ongoing learning collaborative, those ongoing coaching calls, that's sort of our attempt to try to streamline kind of what we have learned on the ground. It's our way to kind of feedback information on what we have seen, what we would like to see, you know, within reason. So we're trying to hit, you know, this at all different angles all at the same time, and it's been working pretty well.
I just want to add, from a perspective of actually having visited a lot of California jurisdictions in the process of the strategic plan, that linkage varies widely from community to community, depending on how developed the network of providers is in general. And so we saw, like, when there is like a provider, like in a Southern California jurisdiction that is close to the border, that may be linked to the other provider on the other side of town, and they're like the only options, and staff turns over, and so there's no real network to actually do, and they may have a neighboring county come in and provide services outside of their jurisdiction. And so there's a lot of barriers in depending on where you are. And I saw the question from Felicity Majesty in the chat about what it would be like to have a step-by-step method to linkage of care for transgender patients. In other jurisdictions where there's a very developed network, we've seen individuals sort of ask that question for and think about how to develop a very specific system of care for transgender individuals. So San Diego County, well-developed a linkage network. They are kind of moving into a different a set of EHE goals around thinking about how a transgender service initiative might be framed so that they can first kind of build it from the ground up with input from the community, and then make it so that it's a system of healthcare for transgender people that includes a linkage to care for individuals that are positive, including all other supportive services and prevention services. So it's very exciting to see that, but it's a wide range of like how this happens in different parts of the state, and we like to see that disparity be evened out by having the state support more local systems of communication and development as part of our strategic plan going forward, so that people can have more of a standard way of interacting through a network.
Great, thank you all so much. And we do have a few additional questions coming into the Q&A now, so we will get through as many as we can during our time. If you have additional questions for folks on the line, feel free to continue to enter them in the Q&A, and I will follow up with our amazing presenters if we are not able to get to all of the questions on the line, and we'll make sure to get responses to you all after the session. One of the questions that just came in was, can EDs submit a referral to the LA County Rapid and Ready navigation email for rapid linkage? And what's the outcome of that so far? So that's for you, Kim.
Love this question. We actually have yet to receive one via email, but I would love to. To be clear, the phone call, the warm line, is the fastest way to reach one of us. The email is really there if we can't be reached by phone, or if it's after hours, something like that. But yeah, if anyone in the LA County area wants to give us a call at the number, I can put it in the chat too. I know it's in the presentation. We are happy to take it from there.
Great, thank you. And while we're on you right now, Kim, one other question for you is there an appointment availability system in place that health centers can access directly for linkage, or do they have to call your Navigator warm line to access that information?
We have to work directly with clinics. So again, that depends on their staffing. It depends on a lot of things, but we don't have any direct appointment scheduling access.
Got it. Thank you. Okay, and then I think the last question we have in so far is, can you address your robust linkage and access to care programs in the jails and prison system in your jurisdictions, along with any outcome data about linkage rates? And so maybe starting with you, Megan, do you have anything to share on that question?
Yeah, so I know that there is a linkage team at Santa Rita Jail, which is Alameda County's county jail. And they are part of the East Bay Linkage and Retention Network, which is sort of one of the working groups of East Bay Getting to Zero. I know we've also, forged some collaboration with the Alameda Health System HIV team and emergency department team, just because they're such a large source of new diagnoses, and also folks who are out of care sort of floating through. So there have been those direct connections between agencies. And I know all of our member clinics know who the contact is at the jail, particularly when they're looking for out of care folks. If someone is diagnosed at the jail, then of course it's sort of on the the team there to link them to the appropriate provider upon discharge.
Thanks, Megan. And then Leroy or Kim, do you want to address that question as well? Any comments about linkage to care in the jail and prison systems?
I just think it tends to be a gap in how we're looking and serving that particular population. I think it needs to be addressed. I think that one of the things that we have in some jurisdictions where the state supports ADAP in jails and prisons, and we'd like some of that money in savings for custody settings to come back to public health and fund some of these things that would support individuals linking to care and prevention before they're released. We have in the strategic plan, actually, I think a lot of individuals in different places where there are that work with state prison or jails suggested that PrEP initiation has to be something that we have as a strategy in custody settings. As well as naloxone distribution and some other things. So there's some fairly kind of radical things, not so radical, but like some things that we really need to support, I think, in overall in the strategic plan. But I consider it a gap, and I think it's a gap that needs to be met with different things. And in the strategic plan, we suggest that different new data systems, new integration, low barrier linkage for individuals, and a lot of harm reduction also as part of those processes. But I'd love this. San Bernardino County is one of the counties, I think, that is funding some different data systems with their local jail setting and a collaboration with the sheriff's department. So we're looking for ways to build these data systems and that will track some of this information and how well we're doing.
For me, this is actually a topic that's near and dear to my heart, because I actually worked in the jails exclusively for a couple of years. Over, I'd say probably about the past 10 years, we've always really thought about, how to best treat and link folks who are coming in and out of jails. I say in and out of because we learned very quickly that a lot of people come in and out. So that, of course, poses a huge barrier, in addition to, homelessness, substance use, all the other things that have already, come up. Right now, the model that we have, we know is not ideal. We are actually dealing with a few kind of structural issues, just sort of due to COVID, sort of post-COVID. So we currently have a system in place where we have transitional case managers who are contracted to work inside the men's and women's facilities. And then we have medical providers that we work with and sort of collaborate with in there. But as you can imagine, that requires a lot of kind of phone calls and emailing, kind of confirming. So it takes a bit of time to do all that. We do have our partner services staff who are working custody cases. But again, that's only kind of hitting new diagnoses and co-infections with other STIs. So we're not hitting kind of that full population of all HIV positive folks. But I will say that we are in the sort of very early pre-planning stages of really trying to overhaul this. And we all know here that it's long overdue. We really have this dream of hiring, a robust staff of social workers who work inside and outside, really kind of bridging the gap and really kind of trying to do away with the concept of a warm handoff, which is what we sort of attempted before. We really want to see one person see folks on the inside, see them on the outside, do sort of the same follow-up that I described with our rapid team to really mirror what everyone else is doing, either in LA County or in some of the other health jurisdictions. But more to come on that, hopefully sooner rather than later. But I think we're going to get there.
Wonderful. Well, I wish we could chat much longer with all of you. Thank you so much for spending time with us today. I do want to also thank our amazing participants for your great questions. Really appreciate your engagement. And I want to note that, as usual, I will send a follow-up email out after the session with our quick evaluation form. Would love to hear any feedback you have about this session and suggestions for future sessions. And I'll also share the slides from today and a link to the recording. And again, I just want to thank you all so much. Thank you to our panelists for sharing your amazing work and wisdom with us. And thank you to our wonderful participants for your engagement today. Have a great day, everyone.